Well, as Eric said, I'm an endocrinologist. I'm really delighted to be here, and I'm delighted that we have such a great turnout. I'd like to mention first this sort of philosophy of life that I'd like you all to entertain, this idea that you can live long and then die short. In other words, most of us see with people around us that there's kind of this slow fade over time. And the reality is that while we're all here talking to you, it's with the idea of keeping you at that peak level of performance as well as you can be, as long as you can be well, and then maybe we'll just die in our sleep, okay? So I know that really, in real life, we get little things that happen and we see these down ratcheting, but let's try and keep it fixed because it's much harder to fix it after it's broken. Dr. Rudin has done a great job in talking about risk factors, so I'm not going to go over that again, but I am going to point something else out to you. This looks at how well we're doing as a general population in controlling risk factors. You can see that the red is not good at all. The yellow is not great, but in the ballpark, and the green is great control. So if you look to your, I guess it's, where am I? There we go, I got it. If you look at the middle column, that was the diet feast that Emily was talking about. Virtually none of us are in that ideal candidate that she was talking about. And if you look to the right where it talks about cholesterol, blood pressure, and fasting blood sugar, these aren't great either, but I want to point something out here. Just because these people are in the green doesn't mean that they genetically are perfect and doing all the right things. It means that they're under the care of someone who's helping them achieve that, okay? So just because you have these problems doesn't mean that there aren't things we can help you to do about them. What I'd like to point out is one of the risk factors, of course, is that of age. As we get older, our risk increases, and it increases significantly. The recommendations as far as cholesterol, which is the first thing I'm going to talk about, in statin therapy, ends right here at 79. Beyond that, we're kind of like totally not sure what to do. There's studies being done to look at this further, but I want you to realize that the next step that I'm talking about is for those 79 and below. And how we determine your risk and whether your cholesterol needs to be treated and to what aggressive degree it needs to be treated is based on these risk estimators. And you can pull this up. It's American Heart Association, American College of Cardiology. You can pull it up and you can put in your age and your cholesterol and your good cholesterol numbers, whether you have blood pressure problems, et cetera. And then it will give you a number up here at the top that shows what your risk is of having an event over a 10-year period. When the risk gets to 7.5% or above, then we say you need to be treated for your cholesterol. You can see that this gentleman, he seems like he should be pretty okay. I mean, his age is 55, his total cholesterol is 200, his HDL, the good cholesterol, is 40. His blood pressure, he is on medication, but it's well controlled, and yet his risk is still twice that of the normal, all healthy parameters population. The other group that we think about treating are those who've already had an event. They've had bypass surgery, they've had a stent, they've had a stroke, they've had an MI already, a heart attack already. These people are already much higher risk for having an event. Those people need to be treated with statin therapy, okay? What's intriguing is people with diabetes who've never had an event should be being treated with statin therapy. And the reason is that they are considered as a same high degree of risk of somebody who's already had a heart attack. The risk factor modification is the cornerstone of preventing another event. So what I'm speaking about, because of the issues that come up in talking to patients about statin therapy, is Eric knows that this is a hot topic. So let's talk about it. First, before I get to the statins in general, this is the healthy population. And then we have patients who have had a heart attack and what their risk is, of dying over the next whatever number of years. And then we have the patients who are diabetic who've never had an event. You can see that these are all in the same they're in the same curve. In other words, they haven't had a heart attack, but they look like the same person who's had a heart attack. But what I really want to point out here is a patient who's a diabetic who's had a heart issue and is not on a statin. And the reason I point this out is we're going to be talking about diabetes, and I have patients who tell me, I'm not going to start a statin. We dialogue about this and we talk about it, and finally I just draw this curve. And I say, which line do you want to be on? I mean, because not making a choice, or at least head in the sand, is actually making a choice. So you need to know that you might be making a choice that is a really downward spiral. So I just want to reiterate that because sometimes we are trusting our doctors. The overwhelming evidence with statin is that lower LDL is better. The first statin was introduced in 1987, and so they've been here for over 30 years. They've been extensively studied. Hundreds of thousands of patients have been studied, and they're very potent at getting the LDL cholesterol low. And the LDL is the bad cholesterol. Clear benefit of using even the more potent, the higher doses in patients who've already had an event who are at high risk. And someone was asking about, somebody was asking about amount of cholesterol. So when you look at this, this is just taking 170,000 patients that were studied and sort of putting this data together and seeing, is there a point at which we've done enough, if you will. So these patients are about 130 here, and you can see that their risk of vascular disease drops by getting them to about 100, and you've heard that as a goal for LDL cholesterol. You go down to about 70, it's improved even further. And we don't know exactly where the benefit, where we don't derive any more benefit, but you can see that lower is better across the board, okay? Sensationalism. This is what you're up against too, because you pick up the newspaper or you pull up your tablet or whatever, and you see that statins cause something, whatever it is. It's something horrific. It's some kind of cancer, and you don't know enough about the cancer, but it's something, like that really gets your attention. And they say it doubles your risk. Please listen to this for 1 minute. You don't know whether that risk was 1 in 10, and now it's 2 in 10, or whether it was 1 in a million, and now it's 2 in a million. It's scary, and I don't blame you for being scared. You think, I'm taking a medication that could be doing a negative thing to me. But the reality is what you need to do is you need to pick up the phone and you need to call the office. And you just say, did you see this study? And does this apply to me? And am I at risk? Because unfortunately what commonly happens is people actually just stop their medication. And we don't know that until they get back into the office, okay? So trust your provider. Ask them about whether or not this is something I need to be concerned about. So in this particular group of patients, I just want to go through what people tend to ask and what their concerns tend to be, and I may have missed something, so we'll have some times for questions at the end. First one is liver tests. Whether or not the liver is going to be damaged, okay? So we follow the liver tests, especially early on, to make sure there's no evidence of any liver problems. The reality of significant damage is exceedingly low. They may flutter up a little bit. The liver function test may flutter up a little bit. We don't get excited until they're 3 times normal, so just a little bit of elevation is not worrisome to us. But it may be dose dependent. It may be the specific type of statin we're using, so we can change things. The one that's probably the most common is muscle achiness. This was very intriguing to me because 15% of patients who were on the statin had muscle achiness, and 19% who weren't on the statin had muscle achiness. So what does this show us? It shows us that muscle achiness is very common, especially as we get older. I think it's intriguing because about 30% of the people in the placebo group who were not getting a statin stopped their medication because they were having the symptom. With patients, what I will ask them to do is I will have them stop it for 2 weeks. If it goes away, then we say, okay, let's retry the medication and see if it's related. If it doesn't go away, it doesn't seem like it's related at all, so they discontinue medication. But I don't want to undermine the reality that people have achiness, and some people have pretty profound achiness, and some do on one statin, but they won't on another. So we can work with that, okay? There is a very small risk, but a risk of more severe muscle pain, and that's where sometimes we'll be checking muscle enzymes and that kind of thing. What I like patients to do is call me again instead of just stopping the medication, because the other thing I want to know is I usually want to see what the cholesterol was on the medication, if we were even doing what we wanted it to do before they stopped the medicine, okay? The other thing you've heard about probably is type 2 diabetes. The FDA has made a statement and put it in, the information that we get about the statins, that there is a small increase in risk of diabetes. It's incredibly important to recognize that this generally happens in people who are at higher risk of diabetes, or a patient who's already diabetic and we see a slight increase in blood sugars. We're going to talk a little bit about how to address that and maybe even help prevent diabetes to begin with. Because of that very high risk, remember I told you about diabetics and their need for aggressive therapy, we still give them statins. It's exceedingly important for them to be on them. Neurologic, we had this question, does it make a change in your mental status? Well, there have been reported cases of people having some memory loss. It's reversible once the medication is stopped. It's very limited evidence as to it being a cause and effect relationship. But here's what we need to think about here. We have A is your healthy 25-year-old brain, and B is your 75-year-old brain. And this is normal. This is normal aging. So if you're having some memory issues, that's common, okay? It doesn't mean you're losing it. But what's more concerning is these tiny little strokes that happen. Now, it may be, like Dr. Hermiller said, that you have little clots because you have AFib, but more commonly is these are little tiny strokes that happen. And if you have more of those, you start to really interrupt the brain's ability to think. It's progressive. I'm not showing this to scare you as much as to think about what are the things that help prevent this. The same things that help the heart are the things that help the brain. So keeping your blood pressure under good control, keeping your cholesterol low, the exercise, all of those things are the very same things we do to protect our brain, okay? So what if you struggle with statins? Well, we may decrease the dose. We may scrap that one altogether and try a different statin. What I commonly will do is I'll start low and go slow, and patients who've been on a dozen different types of options, and what I'll do is we'll say we're going to take one pill 1 day a week. And after 2 weeks, you're doing okay, we're going to go to one pill 2 days a week. And then 2 weeks later, if you're doing okay, we're going to go to one pill Monday, Wednesday, Friday. And then we're going to check some cholesterol, and we're going to see where we are. Because our goal is going to be this drop of 50% in your LDL, independent of where it started. If your level was 80 to begin with, we probably want it to get to 40. And that seems like, oh my gosh, 80 is already good. Well, not as good as 40 if you have vascular disease or if your risk is high. Once we start getting you on a statin and getting the maximum dose we can there, if we're still not at goal, we may add a second agent. So if you have an agent like a statin that works on decreasing the production of cholesterol, and then you add another agent that decreases in your absorption of cholesterol, you can see a profound benefit by using small doses of 2 agents instead of having side effects on higher doses of 1 agent. And then lastly, PCSK9 inhibitors. This is the biggest, newest kid on the block. These are injectable medications. They're used every 2 weeks, and they profoundly drop LDL into single digits. So part of the question is how low can we go? Is there a point at which we're going too low? Well, at least in the studies that have been done on these, it doesn't appear that there's a change in mentation, the ability to think on these very low. Now, do we need somebody with an LDL of 9? Probably not. But so we can back off on, because we add these to people who are high risk, they have progressive disease, or they can't take statins. We add it to whatever they're already on. sometimes we can back off on some of the other medications. So let's talk about diabetes. How do you know if you have diabetes? Well, you may have heard of something called an A1C. That is basically, it's called a hemoglobin A1C. Hemoglobin, as it circulates through the body, little bits of sugar get attached to it. The red blood cell, which contains hemoglobin, lasts for 4 months. Half are new, half are old. So that tells us a 2-month period of blood sugars, okay? So what your average blood sugar has been for 2 months. Less than 5.6 is considered normal. 5.7 to 6.4 is impaired, some degree of impaired glucose tolerance. And then above that, 6.5 and above is frank diabetes. Or with a fasting blood sugar less than 100 is normal. 100 to 125 is some degree of impairment. And then above 125, 126 and above is diabetes. I want to spend a little bit of time on this. It looks a little bit confusing, but trust me, you're going to get this in a minute. This is a trial that was done to see if we can prevent diabetes. Okay, so they took people who were pre-diabetic. They were in that gray range that I talked about, some degree of impaired blood sugar abnormality, and they randomized them to 3 different options. One is they just live their life. Okay, that's this right here. The next one was they were on metformin, which is a medication that's traditionally used for diabetics. They were placed on metformin. And the third group was placed on lifestyle modification. The people who were on metformin had a drop of 31% in their risk of developing diabetes. The people who made these lifestyle modifications had a drop of almost 60%, and people above the age of 60 had a drop of 70%. Profound benefit. Tells us it's never too late. Okay, so that's all good news. So what was the lifestyle intervention? And this is key, and I want you to kind of remember these very important things. First of all, we're following a healthy, low-fat, low-calorie diet with the goal of losing 7% of your body fat, of your body weight. So if you weigh 200 pounds, the goal was to lose at least 14 pounds and to maintain it. That I think is exceedingly important because, like, if you read, like, you know, Ladies' Home Journal or something, women say how much weight do they want to lose. It's like 35% of their body weight. You know, I mean, it's like these very high numbers that we're starting with a goal that let's start with realistic expectations, okay? But this is very doable. The physical activity part is just as Dr. Rudin mentioned, where 150 minutes of moderate intensity activity on a weekly basis. 30 minutes, 5 days a week. Sound familiar? 7% body weight. These are the people who drop their risk almost 60% and more if they were above the age of 60. And this is called the Diabetes Prevention Program, and it's being done at a YMCA. There's being done at YMCA's around here. So if you want to, take part in this, call, or you can do it at home. I would say one thing about the exercise. I'll oftentimes, because people have trouble fitting it in, I'll tell patients when you get out of the car, go take a walk around your building before you go in. Do it again at noon, and do it again before you get back in the car. You can incorporate it through the day. There is good information about 10-minute intervals are fine. You can do it that way. And it also gives you sort of the freedom of realizing, okay, when can I fit an hour at the gym in? Incorporate it into your day. There are medications that are diabetic medications that actually have some degree of heart protective effect. And I think if you're diabetic, you definitely want to hear about this. Certainly metformin has been around 40 years now, I think, but it has been shown to have a mild decrease in the risk of vascular disease. Sodium glucose cotransporter 2, we call them SGLT2 inhibitors. They work by decreasing the amount of sugar that is reabsorbed by the kidneys. So the kidneys filter the sugar and then they take a lot more of it back into the system. These allow it to go out into the urine, and these have been shown to have some pretty impressive effects in decreasing risk of a second event and in decreasing progression in kidney disease in diabetics. And then the glucose-like peptide inhibitors, GLP agonists, those are medications that are injectables. They're given once a week. All of these also have a weight positive effect. In other words, people tend to lose weight. They're not weight loss medications, and it's not a profound weight loss, but there is weight loss associated with these. So let's not lose sight of our goal. When you have 400 other things you'd rather do besides get on the treadmill, think about this. Think about the goal that's maybe 20 years down the road, 50 years down the road, because we can get too distracted by the dailies.